I was trying to unmute myself. Hi, yeah, I'm Esther Taborn. So I work for, as colleagues have just said, NHS England, NHS Improvement. And I was just asked, as part of my role in supporting the response to COVID-19, which is the other name you sometimes hear used for this particular virus, I was asked to support that work in the southeast around this particular request, and that's why I'm here today. So what I'm going to do, because I appreciate some people might not have the actual session open in front of you, some people might be on a phone, possibly with the slides either printed out or in some other medium. So because somebody else is moving on the slides for me, it might be more useful for everyone if I just say what slide we're on so that people can keep up, if that's okay. It's a bit disjointed, but it's the best way really we can do these virtual online sessions in the current climate. So if we can move on to slide 2, please. So slide 2 talks about what the virus is, and you can see there I've put a little picture in. Now some of you may well have seen this picture in the national media, but for me anyway, it helps me understand if I can sort of, if you like, see the enemy and understand what it looks like. And the problem we face with viruses and bacteria for that matter in the world of infection prevention and control is that people can't see what they're dealing with. And what we know from a lot of the research that's been done around infection control over the years and infection prevention is when people can't see a danger, it's sometimes very difficult then to encourage them to help prevent a danger. Now, with this particular virus, I think because people are aware of the threats, it's been made slightly easier. However, what that has led to is a certain amount of misinformation and a certain amount of fear. And that's, of course, that's the other side of people having a genuine fear, is that when you get a misinformation and you have irrational fears based on that misinformation, then sometimes that can become unnecessarily worrying for people, which of course nobody would ever want. So this is what we know so far about this particular group of viruses. We've known about them since the 1930s, and they mainly cause respiratory diseases, although for those keen-eyed among you who watch the national media on this subject, you will see there are some very recent studies that are suggesting it might also be a vascular disease as well. And the one thing I must say throughout this particular presentation is this is a virus that we only really properly knew about at the back end of last year, the early part of this year, in terms of this particular type. So therefore, as we learn more about this virus, as more studies are being done, both in this country and internationally, so the science changes. And that's why some of the messages sometimes change, because the more we learn, we update immediately the guidance and the information that's out there, both for the public and as well for providers such as yourselves and providers in the health and social care setting. So if we can have slide 3, please. Now, slide 3 talks about it's just to give you some of the idea of the range of illnesses that can be caused. And again, some of you may have friends, relatives, may have even yourself experienced some of the mild forms of these particular diseases. And some of you may well have experienced some of the more severe forms. One hopes you haven't had SARS or MERS, but I don't know who's dialed in. So that'll give you an idea of where COVID-19 sort of sits in the sort of severity scales. But of course that varies. You will occasionally get an old person in possibly a care home setting, somebody who's quite vulnerable, who at the end of a long sequence of illnesses gets a common cold, and for that's the trigger point that unfortunately, if you like, is the last straw in terms of their lifetime. So if we move on to slide 4, I'm just making sure I keep on top of this. So what you see in the red box there, where it says cough, fever, loss of smell, loss of taste, they are the key indicators that you may have COVID-19, and they are what I am sure you all know by now. It's been all over social media, all over the national press. They are the absolute cardinal key signs that you may have COVID-19. Some of them are also mean that you might have something else, but certainly they are indications, as we heard on in the Prime Minister's briefing last night, to actually, even if you're at home with some of those symptoms, that you present for a test via the website links that were given, and I'm sure we can share those after that, because I think that public health message is important to share in every sort of context. The other symptoms that people tend to report, and again they're not present in every case, so they're not considered key diagnostic indicators, if you like, so the key things that would need to be present. Some people report feeling really tired, a sore throat, pain in their muscles, a headache, shortness of breath. Some people, when they recover from COVID-19, so that they're perhaps 14 days, a month or so down the line, still experience what they describe as a pressure on the chest, an inability to get their breath, difficulty when exercising more than very, very short distances. What we also see people reporting is 4, 5, 6 weeks later are still having a residual cough. And I'll come on a little bit more to answer some questions around that and how long people are infectious for later. But they're the sort of range of symptoms you might see. So certainly in terms of the population you work with and your service users, certainly if one of your service users presented with a new onset cough, a fever, a loss of smell, loss of taste, that would be some of the reasons to be either contact NHS 111, which we'll come on to later, and think about ordering a test via the online portal. So if we can move on to slide number 5. And slide number 5 is taken for some data now that's a few weeks old. But it gives you some indication of the severity of COVID-19 as it was a few weeks ago. And as I've said, this data emerges, so the percentages may well have changed as we currently stand. But what we know is around about 80% of people who get COVID-19 actually manage okay at home. And by okay, I mean like they've had influenza at home. So clearly, for anyone who's had influenza, you know, that means you're unwell. That means you need to be off work. I'm not saying that means you've got a mild cold. That means you're not well, but you're okay at home. If you drink, if you're taking regular painkillers, you can manage. Some have a moderate type of infection that requires some form of support in a hospital setting, and unfortunately 5%, roughly 5%, will end up having severe life-threatening complications which require admission to ITU. The other thing we know, and you'll have heard a lot about this in the press, is that how severe you get it and your likelihood of living, which is what the word mortality means, certainly increases with age. Emerging since these slides were put together, and I'm sure you've heard in the media, Black and Asian ethnic minority groups certainly seem to have an increased risk around this particular disease, an increased risk of severity and an increased risk of mortality. And public health colleagues earlier this week published some detailed data analysis around that I'm sure colleagues will be looking through and making recommendations in due course. So if we can have slide 6. So slide 6 just is an overview of how it's spread. And I like to put this in because I like to put this in context. So can you all imagine for me now, because I'm sure you've all been to the supermarket recently like I have, people going into the supermarket with gloves and a mask on. And you see them going round and they touch the trolley and then they touch the tins of beans and then they're further on down the aisle and they touch something else. And then they'll push their glasses up or they'll fiddle with their mask, or they might even take their mask off and put it round their neck. Then they'll touch something else and they'll touch their shopping list. I actually saw one lady the other day take her mask off, get a tissue out of her pocket, blow her nose, put the tissue back in her pocket, pull her mask up and continue shopping. So just keep that scenario in mind as we talk about how it's spread. So what we know about how it's spread is both direct and indirect. So the direct route is airborne droplets that a lot of research that goes back many, many years suggests can only travel a maximum of 2 meters. And some research suggests less. And you may well have picked up some of that debate in the media this week. But the UK guidance remains 2 meters. So if you're 2 meters away from somebody, or more than 2 meters away, droplets cannot travel any further because they are too heavy in the air. So if you spill a drink of water, it falls to the floor. A droplet is a collection of liquid in the air, and it will not stay airborne for a very long period of time because gravity will take its effect and it will drop. If it drops on surfaces, and those surfaces then become contaminated, we know it can live on surfaces for around about 72 hours. And again, that figure varies, but that's the standard amount of time quoted based on what we currently know. So if I come along in my gloves and touch that tin of baked beans where someone's breathed all their droplets over, and then I touch my face mask then stays on my face, or I touch my glasses and I touch my mouth, then you can easily see how that contact via that surface has reached my face. And that's really behind a lot of the guidance that suggests outside health and social care and the care I'm going to describe that you give in environments with your service users. There really isn't a place for gloves in shops and in social settings like buses and those sorts of places. Actually, you're far better sticking with the basic Public Health England advice, which is around covering your mouth, catch it, bin it, kill it if you cough or you sneeze. It's around hand hygiene with alcohol hand rub or soap and water if available, and it's around not touching your face, because if you don't touch your face, that's the only way the virus won't get to your face if you're 2 meters away from other people and you don't touch your face. You will, and I'll go further on that next, but I just thought this is a really useful slide to try and get some of that basic stuff really in people's heads to start with. So if we move on to slide 7. So slide 7 talks about some of the other ways we know people can contract, or certainly where we found the virus. These are less known routes. We don't see as much transmission in certainly in urine, feces, tears, blood. But what we do say to caregivers and people like yourselves who are maybe supporting clients and service users, if you come into contact with their blood, it might potentially be infectious. But then we'd say that to you, particularly with your client group, about any contact with their blood anyway, wouldn't we? If you come in contact with their urine and feces, then yes, that may be potentially infectious. But so it was before COVID-19, and actually it may well be more infectious with other organisms. And somebody's tears, you're probably not likely to come into a great deal of contact with, but there is a theoretical possibility. So we've got that in there. So if we move on to slide number 8. And this just summarises these key messages for everybody. Hand washing, soap kills and removes viruses and other infectious agents. One of the things I really hope that's come out of the vast numbers of people that have died and been affected by this horrible pandemic is that if it does nothing else, it cements hand hygiene in the publics and healthcare, social care providers. We know alcohol hand gel is also effective. It has to have more than 60% alcohol in it. So it's really important to check, particularly what I am aware that you will use all sorts of suppliers to get your alcohol hand gel. Really check that it's got more than 60% alcohol in it, and it must be allowed to dry. As I've said, social distancing. We know those droplets will not spread further than 2 meters. So if you are 2 meters away from somebody, the risk really does diminish. And finally, the other key message, and again, this is how rapid things change. Obviously, our Prime Minister announced some things 2 or 3 days ago around shielding, but staff who are extremely vulnerable, staff who are shielding, must not work. Now, I know announcements recently changed around that, and that may well affect some of your staff. And I think probably if when we come to the end, you've got specific questions about specific staff members, again, that might be more useful to pick up on a one-to-one basis with public health colleagues who are also on the line. So if we move on to slide 9. The first thing I want to cover then is a little bit about hand hygiene. Now, my apologies if some of you have already had this information from other places, previous courses, etc. I've been informed there's a variety of people that have dialed in, so I'm going to assume no knowledge, and then I'm not going to disadvantage anybody. So we know, and we've known for a couple of 100 years, that hand hygiene is the single most important thing that can be done internationally to prevent sepsis. And I'm going to make the link here to sepsis because most people have heard of sepsis. People have heard the Sepsis Trust on the national television. They're often on BBC News talking about how the NHS must do more for about the amount of people who die from sepsis. If I now tell you, according to the World Health Organization, a large majority of infections internationally, not just COVID-19, could be wiped out if hand hygiene was done at the right time, in the right place, in the right way, consistently. And then you think about, certainly in the UK, how simple our hand hygiene is. In parts of the developing world, that isn't as easy. When they haven't got access to running water, they haven't got access to soap, and they haven't got access to our hand gels. But in the UK, we're very privileged. We do have access, certainly, to soap and alcohol hand rub, and I'm aware that not all of your client service users will be that privileged, so I'm not making that suggestion. I'm aware that when they're not within your facilities and when they're out rough sleeping, etc., I'm aware that they most certainly do not fit in that category because they don't have that access either. So I didn't mean to suggest that. So if we move on to slide number 10. Slide number 10 is a standard NHS poster that if anyone's been in any NHS establishment recently, you will have seen a similar poster put up. And again, I don't mean to speak down to anybody, but if there's a link at the bottom of this slide that when you get the slides, I would really encourage you to click on. So whilst it's important, we can sing whatever song you like, happy birthday, whatever song you want as you're doing this to make sure that people are doing it for the right length of time. But it's really important you cover all areas of your hands. And clearly, normally if I was doing this session to you face to face, I'd pick up on whether you were familiar with this or not. I'd have your hands up, and I'd perhaps take you through it by demonstrating it in front of you. I can't do that in this particular scenario, but if you just have a look at all those pictures up until number 12, and it's very important as well when you put on alcohol hand rub that you go through the same steps. Had the same conversation last night with my 7-year-old who we went for a walk. He found one of those rocks loitering in the street that you're supposed to move around and replace and post on Facebook so of course he touches it. So me being an infection prevention and control nurse, coming through the door, hand gel, gotta put some hand gel on, and of course he just rubs it between his palms and wipes it on his trousers and goes to wander off. That's not what we want people to be doing, and I'm not suggesting that's an extreme sort of example, but I made him stand there and rub it, as you can imagine, rub it round all the areas of his hands properly. So if we move on to slide number 11, for those who are following, this is why you do it. So they did a piece of research many years ago. Now this is very old for people. You can see there, 1978. This was published, and you'll see there the red areas are the areas frequently missed. The orangey areas are the areas less often, and then the yellow areas are still missed. And this is when people were being observed doing hand hygiene. And one thing we know, when you watch someone, they tend to do it a bit better. So if this is someone being observed doing hand hygiene, then you can imagine perhaps what areas were missed when they weren't. The reason why you end up missing these areas is by not going through all the steps that were described on the previous slide. So if we move on to slide number 12. So some top tips about hand hygiene before I move on. is when you're caring for your clients and service users. So in other words, when you're within 2 meters of them, when you're in their room, when you're in their space, when you're in their zone, and that you may not be for large proportions of the work you do, I would recommend really that you're bare below the elbows. Now that's only a recommendation. There's no guideline or specific must do for you guys to be bare below the elbows, but we know from lots of research and common sense, if you've ever been out and been to a toilet, I don't know, in those things called pubs or bars that used to be open, and you've gone into the and you've tried to wash your hands, and you've got jewellery on and a watch on and perhaps something on down to this, you'll know yourself you perhaps don't wash your hands as well as you would have done, because you don't want to get your wrists wet. You've got a decent watch on, jewellery, whatever, and we know that when people are wearing all those sorts of things, they don't tend to go through all those stages. No long nails, no false nails, and cover cuts with a waterproof dressing. And again, we know all those things will really help you promote good hand hygiene. But that's for yourselves, and that's for your staff. That's clearly not for your service users. So if we move on to the next slide. Slide number 13, that will be. So coming away from hand hygiene now, the next most important thing you can do is around cough etiquette. Now, the Catch It, Bill It, Kill It campaign is an old campaign now. It for some time ago that was jointly badged, I think, between NHS, PHE, or might have even been HPS as was. And you'll see there the lady on the right, breathing out these or sneezing out these sort of green respiratory droplets, which are going all over the pole because she's within 2 meters, and that's what people are picking up on their hands. So that demonstrates what we were talking about before. Obviously, the cough on the left hand side of the screen is a little bit more self-explanatory. So if we move on to slide number 14. So clean, high-touch items. So in the workplace, so moving a little bit now onto your workplace and your setting, now we've set the scene. In the workplace, I would say it's some of the things we're really recommending for some of the industries now that are starting to go back to work, sharing workspaces, is think about high-touch items. Think about things like computer keyboards, phones, door handles, those sort of silvery door panel push things that you use. If you've got any electronic doors where you have to push a button do anything, light pulls in toilets, flush handles in toilets, grab bars along the side of walls if you've got those sorts of things in. All of those are what you would call high touch items. Now, in the guidance for hospitals, there is a recommendation that they are cleaned twice a day. And we're in the process of rewriting some of that guidance, and there's been a suggestion for a number of scientists that we increase that recommendation to nigh on 4 times a day. And one of the things I'm going to keep caveating everything I say is that a lot of this guidance is under review. There isn't any specific guidance for your sector, but I would say as often as you can clean those high touch items, up to 4 times a day, would be absolutely fantastic. If you can't do it 4 times a day, 3 is brilliant. If you can't do 3, do 2. And if you can only do it once a day, that's better than not doing it at all. Because as often as you can clean them, you will reduce that viral load, if you like, on those items. I'd particularly suggest you do it between shifts. So if you've got one person using an office desk space and then they hand over to somebody else, I would perhaps make it something that you do as part and parcel of your shift. So if we move on to slide number 15. Slide number 15 talks about your client group, your service users. So you will know yourselves far better than I. It was news to me as I was beginning to work this up with the colleagues on the line, that the vulnerable in terms of your client group are not the elderly as defined nationally, because of the coexisting diseases and risk factors that your particular service users have. It's anyone aged 55 and above. That said, you may have a very vulnerable 40-year-old because of lifestyle factors or comorbidities, other diseases that they have. Pregnancy is a known risk factor. And basically the rule of thumb is if they would be eligible for a flu jab, they most certainly should be considered vulnerable. So if we move on to the next slide, which is slide number 16, that goes into a bit more detail about these conditions that make people more vulnerable. So if they've had an organ transplant, so by that we mean a heart or a lung, if they've got certain forms of cancer, severe lung disease, weak immune system, so there is something called immunosuppressed, or if they're pregnant and got a significant heart disease, all of those things mean that your service users are vulnerable. And also all of those things, if you've got any staff that fit that criteria, might mean that they've been, as I previously said, advised to shield. So in the service users you have, certainly in residential settings or in drop-in, drop-out settings that you may be providing services for, it's important to think about segregation, about if someone presents who may be unwell, who they then are encouraged to mix with. Is there any way that they can be asked to wait or be located somewhere different in the property that you're in, rather than with other people that might be vulnerable? And that's a very dynamic situation, but just to give you some of this information sort of gives you the tools to make that assessment. So if we move on to slide number 17. So we often get asked, and I know when we did the preparation for this session, colleagues said that you would be very interested in talking about what you should wear. And I'm aware that a lot of you will be wearing your own clothes. Some may be in a uniform, and if you do, great, but I'm aware that most of you will be in your own clothes. So if you're wearing your own clothes to work, I would advocate that you follow some of these very logical, sensible, rational things that we've outlined here. So when you get home, launder your clothes after every shift, separately from other clothes, if that's going to be possible. If not, and you can't do it immediately after you get home, I would put them in a plastic bag in your laundry bin, in front of your washing machine, wherever else you store your dirty washing. I'd put them all in a plastic bag somewhere separate so that you can wash them all together at the end of the week or whenever you want to do your washing. Use the maximum temperature that your washing machine will do for at least 10 minutes. Now, most cycles are longer than 10 minutes. Don't overload the machine. Obviously use a suitable detergent, and it's not on there because we're aware that people don't always have access to this, but the other thing we know that will go on to kill bacteria, so I must say it, is a good tumble dry and an iron, and there's nothing that will survive on that linen. I absolutely guarantee it. And then, as I've said there, it's not a particularly good graphic because that's someone with a stethoscope around their neck, but bare below the elbows if you're involved in delivering personal care to anybody within that 2 metre zone. So if we move on to slide 18. And I know that a lot of you will have questions about personal protective equipment, and again, I must caution, and I know I keep saying this, the guidance for your sector is not there as yet, and colleagues on the line from Public Health England assure me that it is under development, but it's not quite ready. So based on what is currently there, the current advice is for if you're going to be giving direct personal care or you're going to be within 2 metres of your client or service user, we're recommending the surgical face masks, the fluid repellent surgical face masks, a plastic apron, a pair of disposable gloves and some form of eye protection, which should ideally be goggles or a visor and not really those sort of plastic spectacles. And it's really important that you wear it and remove it properly. And it's also important you still wash your hands even if you've used personal protective equipment. And going back to my lady in Sainsbury's, what a lot of people don't realise is gloves do not completely protect the hand from contamination. Most of the disposable gloves, certainly, that we are used commonly in these sorts of settings, have tiny little holes way big enough for a virus. Also, a lot of people will contaminate their hands as they're taking gloves off. So gloves actually, if worn inappropriately, can cause more problems than they solve. So it's really, really important that you wash your hands or use alcohol hand gel after you've taken off protective equipment. And if we move on to slide 17, and again, I'm not going to show you that, no, 17, 19, yeah, sorry. I'm not going to play this because it will just completely crash the whole thing. But Public Health England, I've done some really good videos about what's called on here donning and doffing PPE, which is they're very fancy terms that mean putting it on and taking it off. So don't let those terms frighten you or put you off. They are some really good videos, and the reason why I'm calling them their proper names on here is so that if you go searching for this, you use the correct search term in Google. But the link we've put here will also take you directly to those videos, and I would really recommend yourself and all your staff have a look and have a watch of those videos. So if we move on to slide 18. No, 20, I can't count. Again, something to think about and something you'll be shown in the video is how you take gloves off. So you'll see there pictures, pictorial descriptions of people taking gloves off, people grasping a glove by the outer part and pulling it down, pulling it off, and then popping their fingers in number 5 under the other contaminated glove and pulling that down and pulling it off, not touching the outer surface. And I challenge you, unless you already know how to do this, go away, put a pair of gloves on and try and do that. It takes a couple of practices to be able to do it. So have a go. And just challenge yourselves and your staff. Does everyone know how to do this properly if you're wearing gloves? And again, not just for this, not just for COVID, all infection prevention and control precautions. So if we move on to slide 21, it should be. So in practice then, what do you do if you have a resident that's unwell? Well, I'm sure you all know now, has symptoms you weren't aware, wear appropriate PPE and inform NHS 111. And if they don't require you to be more than 2 meters near them, I would recommend that you're not. But clearly if they need your care and they need your support, then put the PPE on, which will protect you if worn appropriately. And make that call and follow the advice and the instructions given to you by 111. So if we move on to slide number 22. So shopping. 2 meters distance. So I don't know whether some of you get involved with supporting clients and service users regarding shopping, or do shopping for clients or service users, but maintain 2 meters distance, only enter the room or flat, or if you need to. If you do need to enter the house, try and be in a different room to the client if possible. Wash or clean your hands according to the recommendation, and try and take your shopping bags with you when you leave, so that they're obviously not staying in the house or flat or room. So if we move on to slide 23, these will all take much less explanations because they're hopefully clarifications of what we've discussed. So I was asked quite a bit about cleaning when I was preparing for this. In terms of you perhaps needing to clean a client or service user's room after they've vacated. I'm aware that they clean, your clients and service users would clean their own room during a stay. So client's service user has vacated. Best thing you can do, provided of course your client and service user isn't still in the room, and it's not cold, is open the windows. You'll have heard Boris Johnson's advice about meeting outside 6 people. Don't do that inside because we know the risk is far greater indoors. That's the principle behind this. If you can fling the windows open as far as they will go, and I appreciate some of them will only open 2 inches if it's anything like NHS hospitals because of risks of people jumping out the window. So as far as they will go, get those windows open. Try and declutter, take as much of the clutter out as you possibly can. You'll obviously be wearing your personal protective equipment as of the last slide. Your household products will be absolutely fine. Detergents, bleach that you would normally use for a terminal or end clean, discharge clean of that particular thing. Personal waste, tissues, continence pads, cleaning cloths need to be correctly disposed, and I would recommend double bagging a lot of that stuff. But as long as you know, you're going into that room and you've got the window open, and you're doing all that cleaning, the room should then be perfectly satisfactory to be used for somebody else once you've done that cleaning. Another question we do get asked quite a bit, we get asked it by, and I'm sure PHE colleagues do, is what about if somebody in there had symptoms? And if they had symptoms in there and they've been taken, perhaps been admitted somewhere, then the rule of thumb is that the virus will only survive on surfaces for 72 hours. So if you're really concerned about that room and the amount of virus that may or may not be in that room, you could just leave the room for 72 hours and then go in, still wearing your PPE, still do all of this, but then you will be absolutely certain that there won't be any virus left in that room because you've waited the 72 hours as well. So if we move on to slide 24. So slide 24 is from an old resource that's come down actually now from the PHE slide. And you'll see that's where it talks about the 72 hours. It talks about washing your hands. It talks about using warm soapy water, disinfectant, double bagging, and using household disinfectant. And they really are the standard sort of cleaning guidelines that we give for outside a NHS type setting. So if we move on to slide 25. Cleaning equipment where possible. So if residents are cleaning their own room now, so if residents, clients, service users, I've been told by colleagues who help me prepare this, who work in the southeast in this sector, that residents will be encouraged to clean their own room, flat, etc. So that's brilliant, and that should continue with their own equipment. If you're taking in a set of equipment into that flat or into that room that you're going to use in other rooms, it's really important that you also clean the equipment. As an infection prevention and control nurse, I have opened some cleaning cupboards. I have been in several homeless hostels when I worked in Liverpool, both in NHS trusts and in care homes. And sometimes everywhere's beautiful, and you open the cleaning cupboard, and you take a step back because there's a mop there with a dirty mop head. And I'm not suggesting this is any of your place. I'm just trying to give you a picture of the worst thing I've seen. There's a dirty mop head sat in a mop bucket full of dirty water. You've got the cleaning cloths sat right next to where the open sort of, if you like, sink is for throwing away the dirty water. You've got stuff piled everywhere. I've even seen the cleaner sandwiches then right next to where all the cleaning stuff was and this dirty water. So have a think. It's not always obvious to people, but have a think about, do we take equipment into different residents or service users' homes or flats? And if we do, how do we clean that? Because once you finish cleaning that room or flat, you need to clean all those things with a fresh amount of detergent and disinfectant, and then make sure you store it somewhere, cleaning cupboard or cleaning drawer or wherever you keep your shared equipment. You need to make sure that that's stored somewhere that's going to be kept clean and not contaminated. And again, this would be standard anyway, because this will help prevent all sorts of infections. Slide number 26. So this is about laundry. So laundry can still be washed. So even if you've got a service user who you've rang 111, they've said, yeah, might be COVID. I'll send that person a test. They've sent the test, and then they're amassing all this washing in their room, particularly if they are they'll be sweating a lot, possibly because they're not very well. So laundry can still be washed even if someone's COVID positive. That's fine. Important things are, don't shake it. Remember we talked about droplets and being released into the air, so don't go shaking the laundry about. Take it into a bundle, stick it straight in the machine, wash it normally as per the manufacturer's instructions. Hotter the better, but you know, if it's wool, perhaps that's not a sensible plan. So manufacturer's instructions. If something's heavily soiled, then sometimes we do talk about saying to clients and service users, listen, are you really sure you want to keep this? Do you want us to dispose of it? And if you do need to dispose of it and do agree that it can be disposed, then double bag it. And again, wash your hands with soap and water afterwards, even if you were wearing gloves and apron, which I'm sure you would have been. So if we move on to the next slide. Waste management. So again, we get lots of questions about what do we do with waste management, and particularly if we think someone might have COVID-19. So remember I talked about all those body fluids it might be present on, and remember I've also talked about what we know is that it will only survive for 72 hours. So what the recommendation is for organisations such as yourselves is double bag all that waste, put it to one side, so a cupboard's fine, anywhere you like, as long as it's double bagged and put to one side where it can't be interfered with, so there's some sort of lock on the door. Leave it for 72 hours and then you can dispose of it as per your black bag waste. And I know that might sound a little, are you sure? But I am sure, because we know that one of the certainties we know is it will only survive for that 72 hours. So you are absolutely fine bagging those things up, including your PPE, and then leaving it. So if we move on to number 28, slide number 28. So this is a little bit of advice for staff. So staff who come into contact with someone, and I'm sorry I've used the word patient there rather than service user, I thought I'd been through that, so my apologies. Staff who come into contact with somebody who may or may not be COVID positive and aren't wearing PPE, they can remain at work. There's no guidance at the moment that they can't remain at work, unless of course, and again remember I wrote this prior to track and trace coming online. So track and trace, this is where I don't mean to complicate you, but things do change on a daily basis. Track and trace may make an assessment. So if one of your clients comes back as COVID positive and they make an assessment in terms of the people they've been in contact with, it may be that if some of your staff or have been in contact with that service user for, I think it's greater than 15 minutes at a distance of less than 2 meters, then they will recommend that that person now self-isolates at home for 14 days. That wasn't the case when I wrote this slide, but that's the current guidance for the track and trace contacts. But what I would hope is that a lot of your contacts with your COVID positive service users, if you have any, are where you're wearing PPE. Obviously, if a staff member becomes symptomatic, they need to go home and they need to self-isolate for 7 days following the stay-at-home guidance. They can return to work on day 8 if they feel better and they haven't got a fever or haven't had a fever for 2 days. So Helen has just messaged in the instant message box for those who can't see it to say hopefully track and trace would escalate this to us in PHE, so we'd have a risk assessment discussion with you, which sounds very sensible to me. Sounds an excellent way forward. So that's around if any of your staff have had contact with some of your service users without wearing PPE, or even with wearing PPE. What Helen seems to be saying there is PHE would help you and guide you through that risk assessment. So that's brilliant. So going back to staff now who feel unwell, if they, on day 8, if they've not got a fever, if they've not got a temperature, they can come back to work. If they've still got a temperature, they need to stay off work until they've not had a temperature for 2 days. The thing, remember I said about a cough and a cough persisting for some time? If a cough persists after day 8, and some people do get quite worried about this, they can still come to work. It's what's the contingent factor is whether or not they've got a temperature. And again, I'm sure PHE colleagues are on the line. If you're in a dilemma and can't quite remember and look at the guidance and can't quite work it through, I'm sure they would be happy to support you in that. But you will have these slides as well. And if a staff member has a household member who develops symptoms, then I believe at the moment, unless it's changed while we've been on this call, the guidance is the staff member needs to self-isolate for 14 days along with the whole household. So if we move on to slide number 29, this is quite a complicated graph on first looking, but then when you re-look at it, it does make a little bit more sense. This is so household 1, person in household A. If you look at the top line there, 7 days becoming ill, can go back to work on day 8. But then if while they're off, let's say their husband or wife, partner, significant other becomes ill as well, then that will extend things to day 11. And if you then get a child, then the 2 children perhaps living in the house or other people sharing that facility, then you will see that extends things to day 15 for them because they've been in contact with somebody who's positive. I probably haven't explained that very well, but the more you look at that graph, the greater sense it means. And like I say, I'm sure PHE colleagues would also be happy to help you work through that. So if we move down to slide number 30, this is really this is really to sort of pull all this together for us. One of the biggest things we've learned about this is that everybody really is in this together, and in the early stages of this pandemic, both internationally and nationally, there was a little bit of pulling apart. And one of the things we've sort of come to realise is that only if all the sectors work together, and all the providers of health and social care work together to provide care and support for people, will this work together. So I think that's probably, oh, I've pressed the wrong button now, sorry. I pressed a button on what I was doing. So if we can have the next slide, please. So one of the things that have been sent out to you, and Karen Simmons, the lady who I know many of you have liaised with to book into this, said that these were sent round fairly recently. So what I said was at the end of this, I would put these on just to make sure you've seen them. So this is in the southeast region, your outbreak management testing protocol there. So it is very small, so hopefully you have seen these and they've been sent round to you. You'll see there the contact details for the health protection teams across the southeast. You will see the monitoring of symptoms in residents as part of welfare checks, key symptoms. So they are the welfare checks that you're clearly doing for all of your resident service users. And if they report with any of them, first possible case in a facility or possible outbreak, which is 2 or more cases, then it tells you to contact your health protection team for advice and to arrange testing. So you'll see that's all outlined there. So if we move on to the next slide, these slides aren't numbered, but there's only 3 of them. This is the next slide is the other document that you will have been sent. So again, it goes through other test options for clients and staff. So this is where I was saying to you the link around the test check. If you have if you have coronavirus, members of staff volunteers working with the homeless population are key workers and therefore can access prioritised testing through the essential worker route. That's in the second box down, and you'll see there's the link to them. And then the very bottom, staff testing if they're symptomatic, can go through the gov.uk testing portal. So all those links are on there for you, all the phone numbers and all the contact details for colleagues who work in that area. And then finally, you've got the summary of the PPE advice that we went through before. A couple of key points on there. Gloves and aprons cannot be used between residents and service users. They are single use and they need to be changed, and you need to undertake hand hygiene between every resident, and that's why those bits are underlined. Masks, on the other hand, you can wear continuously until you either need a drink, or they become wet, or they become soiled, or you fiddled with them, or possibly a client or service user has fiddled with them, which I do know happens from time to time. So the masks you can wear and eye protection you can wear sessionally. The gloves and aprons must be changed between residents and service users. So if we move on to the last slide, these are some key messages. I'm not going to go through everything on that slide. I believe that's been delivered to you in another format, a portrait. Really would suggest that's printed out, that's laminated, that's stuck up somewhere so that all staff have got access to that. And then the final slide should be an opportunity for questions.